Greetings, everyone. Welcome to another episode on Oral Pathology Tuesdays. I'm Dr. Mandana Donahue, and I'm the founder of Oral Pathology Tuesdays and also your host for these events. So, yes, that is my regular checking sound. Okay, so what, today we're going to be talking about excisional sampling of oral cancer cases. When we think about the diagnosis of these cases, of course, it seems very simple. There are three major things to do. One is to confirm the original diagnosis. The other one is to see if the entire lesion is out, so basically marginal clearance and the extent of the lesion. And the last one, in case of oral squamous cell carcinoma, where very often we have radical neck dissections, is to know which neck nodes, if any, are involved. Now, all of these are very important. All of it seems very logical and straightforward, of course. And it is all theoretically very nice and easy. But when you actually decide to do it in the beginning, it can be really overwhelming. So, we thought we will have a lecture and discussion so that you can tell us what you need to know and we can hear from someone with considerable experience in managing these cases as far as the diagnosis goes. To tell you all about it, it's a very short and very concise and to the point lecture, but you can always ask more questions as we go. As usual, to ask questions, you have to just type in the chat. Now, with this, let me bring in our guest today, Dr. Puyan. Hello, Puyan. Welcome to the channel again.
Hi, Dr. Manda. Thank you for having me here. Thank you.
You are most welcome. Of course, now all of you were saying Dr. Puyan know him, I think. Everybody should recognize him. He's been around not only on our channel quite often, but also basically he is very well known on the scene of oral cancer internationally. And he is currently attached to two different organizations within the Tehran University of Medical Sciences. The first is he is a professor in the dental college in oral pathology, and the second is he is in the cancer hospital. With that short introduction, we will go on to the lecture and then we will catch up with him again at the after the lecture. Yes, Puyan, please start. Let me bring your slides. Yes.
Okay. Do you have my voice, Mandana?
Oh, yes, yes. Could
Okay.
you hear? Oh, yeah.
Thank you for having me here. Okay, great. I think this is the second slide. Oh, yes. And yes. Thank you. Hello, everyone. I would like to express my sincere appreciation to Dr. Mandana for her kind invitation. It's a great pleasure for me to be here with you, and I will share some highlights about oral squamous cell carcinoma, about the dissection and reporting of oral squamous cell carcinoma cases. I'm a member of Oral and Maxillofacial Pathology Department, School of Dentistry, and it is a great pleasure for me to be a member of this great team. Also, I'm so delighted to be a member of pathology department of Cancer Institute Hospital for about 5 years. And I would like to thank all of my colleagues at the Cancer Institute Hospital, especially talented, enthusiastic residents. Also, it's my pleasure to be a member of Danish Path Lab, a private lab in Tehran, and I have great colleagues at this lab. Okay, let's get started with a general principles of dissection of a specimen, especially oral squamous cell carcinoma or head and neck cancers. Let me share some details about general considerations, especially orientation of the specimen by surgeons and the importance of surgical margin at the cancer cases, and orientation of the specimen by pathologists. One of the most important issue about dissection of the specimen is orientation of the specimen. You can see here an ovoid piece of buccellated mass which is not well demarcated by surgeon. Then after dissection, you can just report the extent.
I think we just lost Dr. Puyan. He should be back shortly. Right. So this is. In the meanwhile, let me wish everybody happy Dashera, which I did forget. I'm sorry. I hope it's a very good day for everybody. We also have with us Dr. Madura. Hi. Before that, of course, we had Dr. Sandhya. Hi, Sandhya. Professor Joss. Yes, I think by now he must have already gone to teach. And Dr. Shruti, yes. And then who else? Um, Dr. FW, right. And Dr. Qasim. Yes, sorry, I realize you can't hear. He's got
Sorry,
disconnected.
do you have my
Yes, you're
voice?
back. Yes, we do. We do. Yes, you can continue. Are you there,
Hi,
Puyan?
do you have my voice?
Yes, we have your voice. Can you hear me?
Yes, I can hear you.
Okay, please go on.
Sorry for the disconnection. And okay.
What happened? Where are we going?
Okay. Yes, yes, it's okay. Yes,
Okay, all right.
everything is okay. And
Okay, okay.
sorry. Let's go ahead. And I was explaining that the importance of orientation of the specimen. In the second slide, you can see here that a well-oriented specimen at the right side, that this surgeon well marked the superior and inferior of the specimen, and also the right and the left sides of the specimen by sutures. And it's an example of the well-oriented specimen. And the left side, you can see here a dissection, cervical dissection, that well oriented by the surgeon as level 1, 2, 3, and 4, and it facilitates the dissection process for the pathologist. Um, Although there are sometimes cases with complicated oriented specimens, you are supposed to be in connection with your surgeon that aware them about these complications. When the surgeon mark the specimen by multiple sutures that make you confused about the orientation of the specimen. Another important issue about the surgical margin is about if you're supposed to take perpendicular or end-face margin. You may know that an end-face margin is prepared when the tumor is far from the surgical margin, and you are not supposed to determine the distance, to measure the distance between the surgical margin and the tumor. Then you take an end-face margin. In an end-face margin, there is an advantage, which is several times more surface area can be examined than when sections are taken in a perpendicular plane. And there is a disadvantage that the exact distance of the tumor from the margin cannot be measured. Another type of surgical margin is perpendicular. As you see in the middle photo, the exact distance of the tumor from surgical margin can be easily measured. And therefore, when you have a specimen and you want to measure the exact distance of the tumor from surgical margin, I can recommend you to provide to take the perpendicular surgical margin. But there is a disadvantage that it is a very little tissue at the margin is actually sampled in large resections. Therefore, when you want to take perpendicular surgical margin, you must take several perpendicular margin to cover all the surgical margin and to assess all the surgical margin that if it is involved by tumoral nests or not. Okay. But there is an important issue that sometimes there is a difference between the surface of the specimen and the depth of the specimen. It means that when you want to prepare to take a surgical margin, it is important at the first step to cut the specimen vertically, then assess the extension of the tumor. Please do not take the surgical margin just at the surface. And as you see in the right photo, you can see that the tumoral nests are extended to the surgical margin very closely, and it's almost touch the surgical margin. Another important issue is about what does a closed surgical margin mean. Commonly, we use a 5 millimeter in general to define the closed margin, but the final margin is a multidisciplinary integration between surgeon, oncologist, and pathologist. And I highly recommend you to be in close interaction with your surgeon and oncologist to well define the closed surgical margin. But a 5 millimeter is considered as a cutoff for a closed surgical margin. Another important issue is about the presence of epithelial dysplasia at the surgical margin. It is commonly regarded that the mild dysplasia is a low risk and negative at surgical margin. And when you have severe epithelial dysplasia at the surgical margin, it is recommended to be considered as a positive and involved margin. About moderate dysplasia, it seems that there is a higher risk for recurrence and transformation to cancer. Then it is recommended to consider as involved or positive surgical margin. Several studies have been published during recent years, for example, Dr. Singh and his colleagues published a research about surgical margins, and they explained that a positive margin is a margin from 0 to 2.0 millimeters, and a close margin is something between 2.1 to 7.5 millimeters, and a free margin is more than 7.6 millimeters, and it could be a well prognostic marker for the involved or free surgical margin. You can see here that surgical margins could be well marked by inked. At the left hand side photo, you can see here that there is no tumor, and the surgical margins is completely free. And the middle photo shows that the tumoral nest at the right side are very close to the surgical margin at the left side, and it could be reported as the close margin, and it is about 3 to 4 millimeters. And the right side photo shows that an involved surgical margins, that tumoral nest extended to the inked surgical margin. Sometimes you have bony surgical margin and you cannot report at a frozen section study intraoperative consultation, and you're supposed to separate the bony surgical margin using a saw. And after the calcification, you are supposed to meticulously embed the bone in cassette and report the surgical margin after the calcification of the bony tissue. Another important issue is about the orientation of the specimen and embedding the specimen in cassette. You can see here that we have a true example of the specimen that is not well embedded in cassette. Therefore, you can see worrisome appearance of epithelial cells with, dyscratosis, resembling dyscratosis and cellular atypia. But the important issue is about that you can not see any connective tissue. Then you think that it may not be well oriented and well embedded in cassettes. Then, after re-embedding the specimen in the cassette, you can see that there is no epithelial dysplasia and extension to an invasion to adjacent connective tissue. This is just a normal epithelium with hyperkeratosis at the superficial area. Okay, then let's have a look at how can we report the oral squamous cell carcinoma. We commonly use protocol for reporting cancer of the lip and oral cavity based on the template by College of American Pathologists that published in June 2023. If you have an excisional biopsy, I recommend you to include all the criteria that CAP mentioned in the template, including histologic type, tumor focality, tumor site, tumor laterality, and also you must report tumor size, tumor depth of invasion, regional lymph node involvement, because pathologists and especially clinicians and oncologists must determine the pathologic stage of the tumor. Also, some adverse pathologic features must be mentioned in the report, including histologic grade, tumor extension, lymphatic or vascular invasion, perineural invasion, and the extension of the perineural invasion. Also, worst pattern of invasion and a specimen margin status. But when you have an incisional biopsy, it is necessary to report histologic type, tumor site, tumor laterality, and histologic grade. But I can recommend you to search and review microscopic slide for the tumor extension, lymphatic or vascular invasion, perineural invasion, and type of perineural invasion to clarify the situation of the tumor and the extension of the tumor for the surgeon to plan for the treatment and therapeutic approach. Let's have a look at some details about the adverse pathologic features of the oral squamous cell carcinoma. Tumor extension is an important adverse pathologic features, and when you have a mandibular bone or maxillary bone in your specimen, you're supposed to determine if the tumoral nest extended to the bone, especially to the medullary cavity of the alveolar bone or not. It seems that extension to the cortical bone is not enough to report the tumor extension to the bone. You can see here the microscopic slides that tumoral nest invading the medullary cavity of the alveolar bone. At the right side, the nests are large, and at the left side, we can see small sized tumoral nests. Okay, another important topic is histologic grade, that all the pathologists are supposed to report histologic grade. I can recommend you to use the modified Brine grading system for oral squamous cell carcinoma, which includes the 5 criteria and parameters, including degree of keratinization, nuclear pleomorphism, number of mitosis, pattern of invasion, lymphocytic infiltration. And you can grade your the squamous cell carcinoma as well differentiated, moderate differentiated, or poorly differentiated. At the left side, you can see a well-differentiated squamous cell carcinoma with prominent hyperkeratin pairs, and also you can see moderately differentiated squamous cell carcinoma with significant nuclear pleomorphism and small limited hyperkeratinization. When you have a poorly differentiated squamous cell carcinoma, you need a IHC study to determine if the origin of the tumoral cells is epithelium or not. And you can use pancytokeratin and P63 to determine if the tumoral, undifferentiated tumoral cells originate from epithelium or not. It is very important to determine the adverse pathologic features because most investigators believe that patients with multiple adverse pathologic features in earlier stage oral cancer are more likely to benefit from post-operative radiotherapy compared with those with single adverse pathologic feature. And you can see in photomicrograph in this slide that tumoral nest extending to adjacent striated muscular bundles, which is a significant adverse pathologic feature. Another important topic is about depth of invasion versus tumor thickness, which is well determined, well described in 8th edition of manual staging. Depth of invasion is defined as the distance between the horizontal line drawn from the adjacent basement membrane of the normal tissue to the invasive front of the tumor. And it is, as you can see, it is different from tumor thickness. In 2014, ICOR in head and neck cancer suggested that depth of invasion is a better predictive parameter than tumor thickness. And for every 5 millimeter increase in depth of invasion, pathologic tumor size category will increase one level. For example, less than 5 millimeter is considered as the PT1, and more than 5 millimeter, less than 10 millimeter is considered as pathologic tumor size 2, and more than 10 millimeter is considered as pathologic tumor size 3. And as you can see here, when you have a pathologic stage tumor size 4, you have an advanced tumor squamous cell carcinoma. And when you have a 4A, it means that tumoral nest extending through cortical bone of the mandible or maxilla, or involves maxillary sinus or skin of the face. And when the tumoral nest invading masticatory space or pterygoid plates or skull base or encases internal carotid artery, it should be considered as 4B. During recent years, challenges arise that when you have a squamous cell carcinoma with angulated mucosa, it is appropriate, it is recommended to use tumor thickness instead of depth of invasion, tumor depth of invasion. And also other authors during recent years recommended that depth of invasion in at least some cases in which potential differences in the depth of invasion could alter pathologic stage assignment. And also some authors proposed to replace depth of invasion, a complicated measurement with many challenges with tumor thickness in the patient in the pathologic tumor size staging system. Let me introduce histologic risk model as a useful tool to assess risk of recurrence and death to you. You can see here that this model of histologic risk assessment reported and introduced by Professor Brandwein, and she has explained that resection margin status alone is not an independent predictor of low risk and cannot be sole variable in decision-making process regarding adjuvant radiation therapy. These authors suggested three parameter as worst pattern of invasion, lymphocyte host response, and perineural invasion to score histologic risk of the oral squamous cell carcinoma. Uh, Let me finish my presentation by two important issues about squamous cell carcinoma. In recent years, especially in colon cancer, tumor budding is introduced, and the pathologists are recommended to assess tumoralness carcinomas, especially in adenocarcinoma of the colon, and also oral squamous cell carcinoma for the budding and the number of the nests. The budding, tumor budding in invasive front, defined as single cancer cells or cluster of less than 5 cells at the invasive front of oral squamous cell carcinoma. Tumor budding is a simple and reliable prognostic marker for oral squamous cell carcinoma, and it seems that evaluation of tumor budding could facilitate personalized management of OSCC. It is not included in CAP template so far, but I think it will be included in the template very soon. And another important issue is about the association between HPV and oral squamous cell carcinoma. You well know that most oropharyngeal carcinomas are HPV positive. Not most of them, but some of them are positive, and the pathologists are supposed to assess the presence or absence of HPV using P16 in oropharyngeal squamous cell carcinoma. But in oral cavity, it is newly suggested that or in situ or invasive carcinoma, you're supposed to assess the presence of HPV. When you have a basaloid cell within indistinct cell borders and lack of intercellular breach and increased nuclear to cytoplasmic ratio, you are supposed to assess the specimen for the presence or absence of the human papilloma virus. You can use immunohistochemical staining for P16 to assess it, or use in situ hybridization. Okay, I would like to express my appreciation to my talented, enthusiastic residents at Cancer Institute Hospital, Elham, Mina, and Mahdi. They helped me to prepare the photomicrographs of this presentation. And also, thank you very much for your attention. And I welcome any comment or question.
Yes, as usual, I forgot to unmute. Okay, thank you everyone for listening, and thank you, Dr. Shakib, for that exceptionally good and very crisp and clear presentation. Thank you so much. Now, while you are getting ready to put in your questions and comments, do remember to hit the like if you like the lecture. And here he is, yes. So let's see what questions come in. And actually, we already have a question, so I can give you that right away while others type. Right. Dr. Malaz has said the problem with dysplasia is that grading is highly subjective. What to do to reduce this issue?
Yes, a great question. You know that we have two grading system, binary and three-tier grading system by WHO. You know, we don't have an inter-observer reliability when using three-tier grading system. And it is a common issue, it is a common problem for the all pathologists around the world. If the problem is about to a general agreement about epithelial grading of epithelial dysplasia. Therefore, I recommend to have an internal meeting with your colleagues at your department to calibrate your grading system, and also additionally to be in close connection with your surgeons, oncologists, to elaborate on the meaning of high grade dysplasia, low grade dysplasia, mild dysplasia, or something like this. Therefore, it seems a general problem because there is no consensus, there is no general agreement about epithelial dysplasia, and I recommend to be in close connection with your colleagues at your department to calibrate the grading of the epithelial dysplasia.
Very true. I also think with all the literature, with all the guidelines, there is finally in pathology a level of subjectiveness
Exactly.
that can
Exactly.
never be taken out.
There are a
There
lot
is
of
always.
efforts. There are a lot of efforts to reduce the subjectivity of the grading system and increase the objectivity. And I know that several investigators around the world are moving to the cytogenetic grading system of the epithelial dysplasia, but it is not it is not well proven so far.
Ah, true. Very nice. Yes. Okay, I saw one more question somewhere. Okay. Yes. Dr. Selvi says, which grading system for OSCC you follow?
I explained that modified Brine grading system. It is a little complicated, but it is well descriptive of the microscopic features of the oral squamous cell carcinoma.
Okay, while more questions come in, let me tell you who else was here. Of course, we went through some of them while you were, cut off. But, okay, so we have from here we have Dr. Sandhya. We had Professor Hill with us, but he had to leave because he had to teach. Then we have Dr. Shruti, Dr. Madhura, Dr. Fatima, Dr. Rasam, of course, Dr. Vijay Lakshmi, Dr. I am not sure how to read that. Mojwat, I guess. I guess that's Jawad. Okay. Then Dr. Subodh, Dr. Varun, Dr. Madan, Dr. Punya, Dr. Manusmriti, Dr. Erika, Dr. Gina, and we have, of course, some saying very nice topic. Actually, I think it is also equally good for academics. Then Dr. Osmani saying excellent presentation from Ecuador. Dr. Nagasudhir saying thank you. This is one of your students saying very informative, Dr. Zohre. And Dr. Madhura also saying thank you. Dr. Nasser, oh dear, he could not join us on the main system. He has listened through his phone. I was wondering how there were no comments from him. Okay, that's what he does say. Super review. Then we have now. Dr. Daniel. Yeah. Congrats for the great presentation. What are your thoughts about TILs and tumor budding with regard to OSCC, maybe influencing pathological staging and impacting in the management of the disease?
Yes, great questions. I have no idea about the tumor infiltrating lymphocytes, but I think regarding the immunotherapy during recent decades in oral squamous cell carcinoma, it will be great. We will have a great change in reporting of the specimens, and we will be expected to report TILS in our reports. But regarding tumor buddings, I think it is another form of worse pattern of invasion and pattern of invasion in brain grading system. Then we earlier include pattern of invasion in worst pattern of invasion in our reports. And also, we included tumor budding in pattern of invasion somehow. Not exact, they're not exactly the same, but somehow we included pattern tumor budding as pattern of invasion in the brain grading system. Conclusively, I think that the invasive front of the oral squamous cell carcinoma is very important in prognosis of the tumor, and it will be included in the report and in the CAP. In CAP template very soon, because of the great impact of the tumoralness at the invasive front in the prognosis of the patient. Several studies have been published during recent years that have focused on the importance of tumor budding, and it is well proven as I explained, in colon adenocarcinoma, and all the pathologists, general pathologists, GI pathologists are expected to report tumor budding in colon adenocarcinoma, and I'm almost sure that we will report it in upcoming years in our path reports for oral squamous cell carcinoma.
It's a good question and good answer too. Okay. Now we have, of course, Dr. Muhammad saying thank you. Oh, Dr. Nasser has managed to send us a question. Okay. Your
Exactly.
opinion on relying on markers for assessing dysplasia, PDL1, and other markers.
Exactly. Several markers have been introduced for grading the dysplasia, PDL1, P53, and also I have published a study a few years ago about the importance key 67 to assess the extension of proliferative activity of epithelial cells through the epithelium. And I mention again that there is no consensus, there is no general agreement in WHO and other professional gathering. But I'm hopeful that in upcoming years, reliable markers be introduced to assess the grade of epithelial dysplasia of the oral cavity.
Yes, that would indeed be very helpful if we could have markers.
Exactly. It's very
Really makes
good
so much
point.
of a difference. But it has been a ongoing search now, I think, at least for 30 years that I know of. So that seems
Mm.
like a long time. Yes. Okay, Dr. Vivek Gupta says, very good presentation. Sir, a very new insight that enlightens us in a new way. Thank you again. And Dr. Nasser, of course, is supporting your views. Yes, thank you. So I think, oh, how is that we have? Right. And Dr. Mala says that would be great to have such markers.
Exactly.
Yes. That is like the stuff dreams are made of, no? As far
You
as
know,
pathologist goes.
two important issue about the markers are the reliability of the marker, and also the markers must be well prognostic of the risk of transformation of the epithelial dysplasia to a invasive carcinoma. The complication about this topic is about these two issues.
Yes, and one is actually more complex than the other because you
Exactly.
might be able to identify that it is, say, severe dysplasia, but identifying that it's going to actually progress to cancer is an entirely different thing.
Exactly.
Since we already know that so many of them can literally regress at any time, and we do not know why.
Exactly. Additionally, I had a meeting with Professor Saman from King's College of London. He explained that when we have about 11% of the oral cancer that directly originate from a normal mucosa, that all of grading system at the moment are questionable. That it means that we have a lot of normal epithelium regarding the common grading system, two-tier and three-tier grading system, that cannot grade the epithelium. And regarding this grading system, we can review the microscopic slides and we see and we say that it is normal epithelium, but 11% of this epithelium transformed to oral cancer. It means that we need a cytogenetic study and cytogenetic molecular biomarkers to assess the epithelial dysplasia.
Very interesting. Yes, it will be interesting to know this 11% transformation is like after how long?
I don't remember how long does it take to transform
Hmm.
from normal epithelium to a
Yeah,
oral invasive cancer. Um, I don't remember, but it was very surprising that when we have this number of this of the lesions that originating from normal epithelium, it's the common grading system may not be helpful enough.
very true. Very, very, very true. Oh, nice. We also have Dr. Nazanin with us. Hello. Thanks a lot for a good presentation. And Dr. Mala said, is there any future studies for including cells and tumor microenvironment in grading systems like CAFs?
Very
Also,
important, and
s-
through comments, because carcinoma associated fibroblasts are very important, and the microenvironment of all carcinomas, invasive carcinoma, and special oral squamous cell carcinoma has important role. Even in oral epithelial dysplasia, underlying connective tissue seems to have a great impact of the progression of the epithelial dysplasia to an invasive carcinoma. I think it's an open way to study.
very true. It really is. There's a lot about the microenvironment, especially I think in a lot of ways the fibroblasts that can be done. Because I've always found it very interesting that normal fibroblasts, before they become cancer associated, before they are changed, normal fibroblasts actually have a tendency to stop the movement towards cancer. They are
True.
anti transformation. They do not allow the transformation of the cells, but only after they have been modified by the epithelial cells that they actually promote it. It's a very interesting thing. If we could find the difference and how that difference happens and stop that, we might have been able to do something.
It's a great question. An epithelial mesenchymal transition, carcinoma-associated fibroblast in developing oral squamous cell carcinoma. The role of these cells are very important and need to be investigated.
Yes, very true. Yes, Dr. Malaz also says, yes, very interesting phenomena, EMT and MET. Yes, Dr. Daniel has right. Says apart from that, the current staging scheme for DOI in oral squamous cell carcinoma may not be prognostic across all oral cavity subsites. What are your thoughts about cancer associated fibroblasts and the OCC stroma?
True. You know, we have multiple cases, oral squamous cell cases in our center in Cancer Institute Hospital and also Danish Path Lab. In all of them, for resections, we assess depth of invasion. When we have a oral squamous cell carcinoma of lip and oral cavity, we assess depth of invasion and report to the surgeons. It depends on the treatment plan designed by the surgeon and oncologist. What do they think about the depth of invasion? About cancer associated fibroblasts, you know, in routine practice, we don't assess the tumor for these cells, but it is not included in routine practice in the templates in CAP template. But I think they will come to the to the path report very soon in upcoming years.
Yes. Dr. Vivek says, can research in dysplasia markers be initiated and given in PG course of oral pathology? Here in our dental colleges, San ma'am, please, if you can throw some light on this. Or as a continuation to the same question, or in our PhD course in oral pathology.
Yes, it's a great topic for research, and I recommend Dr. Mandana to invite Professor Keith Hunter and also Professor Saman from King's College of London. They have a great experience on this title, and also I forgot. I attended a great meeting in Antwerp, Belgium, about 3 months ago, and several investigators shared their experiences about epithelial dysplasia and the markers well representative of the malignant transformation of oral epithelial dysplasia. I will share the name of the investigators with you, and I think they will present their research in your channel, and it will be very informative for the audience.
Yes, that's true. Thank you. Always looking for more people to get, anyways, and it always really is good to get experts. So, yeah, coming to one thing about Dr. Vivek is that one of the ways now the problem with doing things during PG dissertation is that the duration is too less for you to have a really good finding at the end that doesn't have with that to end with that small little caveat which says this was too small a sample, too short a duration, and it needs further studies, because that really doesn't go anywhere. Or what you can do, I mean, what we used to do in the department and courts was You start with anyone, whatever marker you want to try, and then you batches of pages do work on the same thing, each batch building up on what was already done. So at the end, maybe after three or four different dissertations are done, then you actually have a very good result and something that really will stand, you know, what I would say, analytical checking and have that value. Right. So Dr. Nasser is also suggesting Professor Ali, yes. And Ali Carmen. Ali. Okay. And yes, we'll definitely. Oh,
Mhm.
Professor Ali from the UK. Yes, definitely. Okay, let's take a couple of last questions. And right, thank you for considering. Only reinforcing the link I sent is from a recent paper from Heather Neck suggesting that DIY may only apply for oral tongue squamous cell carcinomas and not others.
I do agree with Dr. Daniel because, as I mentioned, that the angulation of the specimen in different parts of the oral cavity may confuse the pathologist, and I can confirm your suggestion that it may be just useful and helpful to assess depth of invasion in tongue squamous cell carcinoma.
Thank you. Yes, and for those interested, Dr. Daniel also is going to be coming on the channel, I think in December.
Mhm.
So you can hear from him directly too.
Exactly.
Right.
My pleasure.
Dr. Nasser says work with the same, I believe they're collaborating. Yes. Okay. Right. The last we have is another thank you. And I think it's time. Yes. So let me say thank you to the audience for being with us and for really taking part. Interesting questions, active participation is always what makes it more interesting and worthwhile. So thank you so much, everybody. And right, now I have your little certificate.
Great. Thank you very much. Thank you for having me here, Dr. Mandana. It was a great pleasure for me to meet you again, and I'm very hopeful about our upcoming collaboration. And thank you very much, the audience, the attendees.
Thank you, dear Puyan. It's always, you are effectively one of those people who is essentially a part of Oral Pathology 360. I don't see you as not being a part, you are a part. So you're just sort of once in a way turning up in the lectures to really give a lecture. But I think I have to tell everybody also that he is one of the people who is always there when I need help. And that's really great to know. And thanks a lot.
My great pleasure.
Thank you. We do hope we will have you back soon. And it was very nice having you today. Thank you so much. And with that, let me go ahead and tell you all about next week program, which is also about cancer, but this one is about managing the side effects of cancer treatment, that is, all cancers. This is how dentists will manage the side effects of cancer treatment. It's being done in association with Virtual Dental Academy, so you may find that the links that are provided will take you to the Virtual Dental Academy channel. Don't worry about it. You can also watch it there. You can also watch it right here on our own channel. And yes, oh, and I have to share one more thing with you all before we say bye. You may have noticed today that next to the subscribe button, there's a new button saying join. Well, that is just so that you will join our community. And this it's basically while I love sharing and producing and making everything that goes on in the channel, and we will continue to do that, and all the content will remain available. The basic content and the weekly live streams will not change in any way. and will remain available to everybody. But we are just making some additional things available to those who join. And you can just check out and see what are the things we get. Basically, really, it is just to support us. So, let's just support a channel that you love, at least I hope you love, and help us to continue making the programs that we are making. Check it out. Anyways, I will come up with more details about that. I just did not want you to be surprised at that button. Okay, before we go on, we have some more uh, people who just, I guess, joined us. Dr. Murad Khani is saying thank you. Dr. Mala is saying thank you. And yes, lots of other people. Dr. Daniel saying, thanks so much. It was brilliant. And I have sent the link to all my staff and students from the Clinical Research Division of the National Cancer Institute for those who missed it. Thank you so much, Dr. Daniel. Yes, and thank you for attending. And Dr. Jawad saying, Dr. Shakib is one of the best professors that we have in terms, and we're always learning from him. And I think I can definitely say he would be a great professor from whatever I have interacted with him. And yes, thank you so much for being here. Do remember, if you're not subscribed to the channel, please hit subscribe so that you will get more content from us. You will know when we have another event, and we always have an event on Tuesdays at the same time, a live stream. So join us again, and well, have a wonderful week and see you all next week. Till then, bye, be safe, be happy.